thanks a lot again for everybody that came here today and all the speakers. It's really fun for me anyway, and hopefully not too stressful. Okay, so final talk. I'd like to talk about a little bit about the item-based approach that we have been using for neuropsychological testing for the purposes of, I guess, early detection of pathology. So I mentioned already, obviously, we've talked about it. The most common pathology underlying late onset dementia is Alzheimer's disease. And there are two primary, I guess, pathological marks in Alzheimer's disease, being amyloid deposition, which in the CSF that we talked about before from Mainara's talk was measured with amyloid beta. And then you have tau pathology, which is measured by, neurofibrillary tangles in the brain. And then with CSF, for example, or PET, you're looking at the levels of, in the CSF, you're looking at the level of tau. As I mentioned in the introductions, there are ongoing clinical trials, and with mixed success, but with approved anti-amyloid drugs. And the idea now is also to be targeting people as early as possible because there is less pathology. So if the drug works, clearing out the pathology, you want to be able to give it to people as early as possible. So in a way, it becomes important to be able to carry out effective early detection, early diagnosis in people that are at the preliminary stages of the disease. But that's not the only reason why early detection can be useful or important. There are also, I guess, more psychological or more human touch related reasons. So for instance, having the information that you are at elevated risk or developing the pathology is important to plan your future, to get the important information that you need to plan your financial affairs and everything else, and obviously for the family to be able and know what to do. Now, early detection, as I mentioned at the beginning, we're looking at diagnosis that will be biologically based for the future, presumably, if the trend continues. So a diagnosis will be based, like if you get diagnosed for a disease, looking at white blood cell counts and stuff like that, or specifically HIV, where you have specific markers that can be detected. There will be specific markers also for Alzheimer's disease and presumably eventually also for other types of neurodegenerative pathologies. This is great in a way because you can get a more objective diagnosis, although, as I said, it's controversial because there are a number of differing opinions as well. The problem with that the problem with that is that if, for instance, you're basing your diagnosis on PET scanning, let's say, the availability of a PET scan is not very wide. So, for instance, if you are in a region of your country where that is not accessible, you won't be able to be diagnosed with a PET scan. If you are in a country where perhaps in a developing country where access is even less, you won't be able to have a diagnosis with a PET scan. Now, the future is presumably blood markers. And again, blood markers is great, but at the moment, it's still not available. It's still not fully developed, and it's still expensive. And again, it does require some technological knowledge and expertise and training that is more advanced than, I guess, what I'll get to, which is eventually neuropsychological testing. The problem is also global. This is from 2019, but these get constantly updated. Dementia prevalence is expected to increase. We all know that, but it's expected to increase, especially across the developing countries, low middle income countries. So why you say, okay, it's increasing in the UK, it's increasing in the US and so on, which is often what you see the statistics being about. It's also increasing in developing countries. And obviously, developing countries will be where perhaps access to these more advanced screening technologies or diagnostic technologies may be more difficult. So what we have been trying to do is sort of like focus on low-cost detection, low-cost diagnostics with our approach, looking at obviously tests that are accurate, otherwise there's no point, that are affordable so that they don't cost too much money, and that are accessible in the sense that they're easy to use, that don't require too much training, they're easy to get your hands on. And we have focused particularly on neuropsychological testing, which is the old way of diagnosis dementia, I guess. But what we've been trying to do is take old school neuropsychological tests, break them apart, and trying to find, not invent anything new. I'm not trying to sell you a product. You already have it in your clinical practice. You can take it apart slightly or follow new directions, and you can extract meaningful metrics that are easy enough to extract. They're more accurate than the traditional metrics at no added cost and not too much more of an effort. And essentially, we've been doing this by doing item-based analysis of tests, specifically memory tests, but you can apply it to also things that are not memory tests. So memory is cool, right? So give you an example, 2 common ways of assess memory performance, let's say in an older adult, but also anyone really, is to use a story or to use a list. Okay, psychology, we like lists because they're very well controlled, but the stories are also quite common for testing. So a story, you have literally a story. So elephants love to eat leaves, grass and bark, etc., etc. Okay, the story goes on for a while. Then you give the person the story, and you see how much of that story they remember. Usually, you want to test them immediately after the story, and then after a delay of could be 20 minutes. Similarly, with a story, you have similarly with a list, you have a list of words. This is all verbal learning, okay? Non-verbal is a whole different kettle of fish. You have a list, and you'll ask the person to, usually they will listen to the list that you tell them, and then there'll be various repetitions, some immediate and some after a delay. The traditional way of scoring these tests usually is to look at how many words or ideas the person remembers, which is great. But also you can do item level analysis as we've been doing. So you can take a story, you can look for common nouns versus proper nouns. You can look at adverbs, you can look at verbs, you can look at adjectives and so on. So you can look at lexical components. You can also look at the first part of the story, the middle part of the story, the last part of the story. You can look at the order in which people remember things. With a list, obviously you can look at the specific quality of the words, but also you can look at the first word, you can look at the second, third, and so on and so forth. So you can do a lot of extra work on data that are already available using tests that people already use. So for the purpose of this talk, I'm going to condense it to one thing, which is serial position effect and specifically primacy effects, just also because it's limited time. But serial position effect is the idea that when you learn something, particularly typically a list, you'll find a curve whereby you remember things that were learned at the beginning of the list better than things that were learned in the middle. And then you'll remember things that were learned at the end of the list better than things that were learned in the middle. So you have a curve, okay? And the middle part is always the bit where you don't remember things as well, which is why we put Elisa in the middle. No. Okay, and this is the first study that I could find a while ago while I was looking at the literature, looking at serial position effects and dementia. This is a study by Miller in 1971. Looking at presumably early onset because they were about 60, so on the cusp of early late onset. And what they did find was that people with diagnosed dementia had, these are controls, so they had a very well-established serial position curve. So they had a primacy effect, which would be remembering things early, and they had a recency effect, remembering things late in the list. Whereas people who were diagnosed with dementia had no primacy effect, or a very weak primacy effect in this test, whereas they still preserved some kind of recency effect there. These results were replicated, and this was immediately also, we're looking at testing immediately after presentation. But you can see how there is a difference, particularly here with the primacy effect, which is what I'm going to follow on for the rest of the talk. Not so much on the recency. These blobs don't serve any purpose. Okay, so interestingly, you may also ask, why are you looking at story if you're looking at the serial position effect? Because intuitively you may think if there is a story, you're not going to find a serial position effect because the story is structured. So people are not necessarily remembering things better at the beginning of the story, the end of the story, the middle of the story. But actually, you do find a very clear serial position effect with stories as well. We've repeated it quite a few times. So the other thing is that I like delayed tasks. Dorothy mentioned consolidation a few times in her talk. You're not going to find much of a consolidation effect if you're looking at performance right away. You need to usually wait a little bit to see if the person's actually consolidating the information or not. So I do like looking at delayed performance. And I'm going crazy now with this thing. Somebody should have told me stop. Anyway, so if we focus on primacy, we're looking at the beginning of a story or the beginning of a list. And this is a short review of some of the findings from slightly older studies, 2019, to the more recent ones. So again, here we're looking at a list. For those of you who are familiar with this type of test, the raised AVLT is 15 words, unrelated semantically, and they're presented 5 times, and then there is a delayed recall after about 20 minutes. I say after about 20 minutes because obviously there are slight variations. But anyway, that's supposed to be. And here we looked at 191 individuals who were cognitively impaired at baseline and followed them up for about 8 years to look at whether primacy specifically predicted their risk of having mild cognitive impairment after about 8 years. Mild cognitive impairment is a clinical condition that predates dementia proper, where people have some degree of memory impairment. It's defined in different ways. Over time, the definition changes slightly, but for our purposes, is a form of cognitive impairment. And indeed, compared to the standard metrics that we normally get, so the total number of words, the proportion of delayed primacy or delayed primacy performance was a better predictor. So predicted the decline better than the standard traditional tests. This is a more recent study, in fact, still under review. I think, yeah, it's under review. Hopefully to be published soon. This one, look, I'm doing it again. This one is from the CERAD, which spells out something I don't remember, but it's a serial test, including a list learning test with 10 items, repeated 3 times, and then there is a delayed recall later on. These are data from the Rush University in Chicago. A much larger sample here. And the reason I like this study is because the outcome is actually autopsy data. Sorry, I can't speak anymore. So these people died, and I didn't, but they looked at the level of pathology within their brain during autopsy. And specifically, the global brain pathology, which is here a combination of both amyloid and tau pathology. And obviously, the question was, does delayed primacy compared to the other traditional SERAD metrics, does it predict overall pathology in these people's brain after death better than the traditional measurements? And indeed, yes, that's what we find. So the best predictor in our analysis was delayed primacy. And what we do find is for about each, so primacy here was the first 3 words in the test, 30%. And across, this is cross-sectional. So if you compare it to different persons, to different people, you're looking at somebody with absolutely 0 primacy versus person with 1 word that they remember from that portion, you get a difference of about 4% in global pathology. So if you're looking at 0 to 3, you have about 13% a difference in global pathology. Importantly to remember, all of these people were cognitively intact. There were no signs of outward dementia at the start. So we selected only people who did not have a diagnosis. And this was the better predictor also compared to the traditional ones. And particularly what we found was that delayed primacy was associated with the amyloid pathology, not so much with the tau pathology, but specifically with the amyloid pathology. So as I was saying before, you can find seroposition curves with stories, and these actually are data from something I did recently, I forget what it is, but these are data from a story recall test. And you can see, let me see, you can see here, let me go back. Okay, so seroposition, so far I've looked at lists, let's look at story as well. I've done work with the logical memory test, which is a very common story recall task. There is usually the American version, but there's also different versions. We have a story with 25 idea units. I've done work with craft as well, which is another story. It's a bit longer. You find pretty much the same things. This is an example between, so you have controls and you have people with Alzheimer's disease here. And you can see the controls. There is a nice seroposition curve with the story, regardless of whether it's an immediate or delayed testing. Of course, delayed testing, they're not quite as good as when you test them immediately after the story because it's sometimes as fast. If you're looking at people with Alzheimer's disease based on biomarker diagnosis, you'll see that there is a substantial drop again in primacy. So after a while, they will tend to forget the first part of the story very substantially. These are studies also looking at, well, the outcome was measured with PIB PET. So Pittsburgh can be PET, looking at the levels of Alzheimer's, the levels of amyloid beta, amyloid load in the brain. And essentially, another thing that I think is quite handy to look at is to look at the level of forgetting, not just look at the performance at immediate versus delayed, but look at also how they combine, how much are we forgetting. And in this case, we looked at, I believe this is CSF levels of amyloid beta, p-tau amyloid beta ratio, which is a good measure of Alzheimer's disease pathology. The higher, the worse. And what we do find is that loss of primacy, so primacy forgetting correlates with that level of pathology, again, more so than traditional metrics. So the more we're forgetting specifically from the first portion of the story or the first portion of the list, the more likely it is that there is some level of Alzheimer's underlying pathology. And that's it. So I'm always advocating for, looking also at the possibility of low-cost ways to detect pathology in the absence of, I guess, better ways, and which are more globally friendly in the sense that it can be translated relatively easy across the world and at lower cost. Yeah, tend to be accurate, more accurate than traditional testing if you're looking at item level analysis. accessible and affordable, and quite partial, obviously, to seroposition analysis, but there are various other ways that we have pursued, including lexical markers and others. We're not trying to sell your product, as I said, not trying to invent something new. Just look at what you already have and how best you can employ it. If anybody's interested, we would like to look at global cohorts. We're often just looking at white North American cohorts, so it'd be interesting to look at global cohorts and ethnic minority cohorts within the same countries as well. We're looking at expanding to visual spatial analysis as well, which is something I'm quite keen on, particularly which is better for global translation. So if you go from country to country, you don't need to translate the test. It's because it's visual spatial. And of course, please do get in touch if you're interested. These are my collaborators, Ainara, who only see on video, and the University of Wisconsin-Madison, and then New York University, National Institute of Health are giving us the money, and no conflict of interest. So thank you very much.